Today is Thursday, February 3rd. This is the Finance Committee, and we are going to hear 7 bills today. The bill hearing order is Senate Bill 83, Senate Bill 88, Senate Bill 169, Senate Bill 186, Senate Bill 240, Senate Bill 260, and Senate Bill 293. Now, the reason there's seats open is because some of the members are in other committees testifying on bills. So I just want people to be aware that it's that time of year where we're all over in other committees. But we're going to start today with Senate Bill 83, which is Senator Simon Ayer. And Senator, would you like to bring up your panel?
Side saddle. Yeah. Okay.
Senator, whenever you're ready.
All right, thank you. For the record, Senator Simon Ayer presenting Senate Bill 83. I worked with the Department of Health and associated boards on this consensus legislation. This bill further expands what we did in last year's Maryland Modernization Military Laws Act to create consistent language in our laws. Initially, this bill was 5 pages, but after working with other health boards, it was requested to expand to 11 pages. This bill modifies the language in the discipline sections of the health licenses through standardization of language, including considering any disciplinary action taken by any branch of the uniformed services. Specifically, what this bill does is updates outdated federal references, such as revising references to the Veterans Administration to be the U.S. Department of Veterans Affairs, update sections to take into account any discipline action by any branch of the Uniformed Services or the Department of Veterans Affairs, as done with other boards where it applies. It adds technical revisions to provide consistent and correct language among other similar boards. I could go into more details, but that's the bill.
Thank you, Senator. David, would you like to go ahead?
Thank you, Chair Vital. I apologize if last week I know you had a little problem pronouncing my last name, but eventually everybody gets it, and I always get a kick out of how people mispronounce it anyway. It's been a long, long road, but fun. Anyway, Chair Vital, members of this committee, thank you for the opportunity to testify in favor of Senator Simon Ayer's bill. For the record, I'm Dave Dragic, a retired Army colonel and the legislative director for the Maryland Military Coalition. Coalition strongly supports Senator Simon Ayer's bill. It increases the transparency of disciplinary actions when added to licenses associated with the 12 specific Maryland boards and health occupations by requiring the inclusion of those actions from the Uniformed Services and the U.S. Department of Veterans Affairs. This makes common sense, as disciplinary actions from military or government service should not be overlooked. State officials need to be aware of them. In addition, while the fiscal note indicates that the bill is a technical change, the significance of adding this requirement is the consistency for grounds of discipline it adds to those Maryland boards, improving the clarity of their responsibilities. So for these reasons, the Maryland Military Coalition strongly supports SB 0083 and asks for a favorable report from the committee. And we would like to thank Senator Simon Ayer for sponsoring this important legislation and appreciate his leadership on this issue.
Thank you. Do I have any questions from the committee? I don't see any questions. Thank you, Senator. That ends the hearing on Senate Bill 83.
Thank you.
Our next bill, is Senator Augustine here? Yes. There he is, Senator Augustine, Senate Bill 186. And would you like to bring your panel to the table, please?
Oh, yes. I'm not sure if folks are here yet, Senator, but so I'll just present and
Okay.
we'll go from there. All right, Senator Malcolm Augustine here on behalf of Senate Bill 370, which is for the State Acupuncture Board, its revisions. Just to start, this has been worked on in conjunction with the Acupuncture Board, and just so that you all are aware. And the bill clarifies that the board regulates manual techniques of Asian bodywork.
Senator?
Yep.
We're looking for 186, State Board of Examiners and Optometry.
Oh, sorry.
That's okay.
I'm on the wrong bill.
I was trying to see what acupuncture had to do with eyes, and I couldn't quite connect it.
Sorry. Give me 1 sec, then. Yeah. Can I get a minute? Okay. What was that?
We pause? No.
Pause, I don't know if Senator Giles' people are here.
Okay,
Can you just give me a,
let's bring up Senator Garland.
thanks.
We'll
Sorry
let you come back, Senator.
I'm not going.
I'm going to do that for everybody, but I'll do it for you. Senator Gall, you're going to present Senate Bill 88, State Board of Examiners for Audiologists, and I think you have Nikki Runge with you. Is Nikki here?
I think she might be in the hall, I hope.
And then would you, if Keena Stevenson is here, can she also come to the table?
Are they in the? I think because it's not quite 2, I suspect that they might have thought to be here at 2.
Okay.
Let me,
I'm gonna go see if I can find her.
We're gonna pause the committee meeting till 2 o'clock.
okay.
Okay, we'll
All
just
right.
pause and wait for everybody. Thank you. Have a 10-minute break. It is 2:00, and we are resuming the meeting for Senate Finance for today, Tuesday, February 3rd, and we are back to Senate Bill 186 with Senator Augustine, State Board of Examiners and Optometry, examination requirements and time period for inactive status. Senator?
Yes, thank you, Madam Chair. And I do have a panel, like you said. So we're going to bring up Dr. Guger Che. He can come on up, and also Ms. Joyner as well, that's the board chair and the board ED. And as I was saying about the other bill, this one too has been done in conjunction with the Board of Optometry. So Senator Augustine here on behalf of Senate Bill 186, which is updating examination requirements and time period for inactive status. And what this bill does is really modernizes the Maryland optometry licensure requirements by aligning them with national examination standards, and requires applicants for licensure successfully pass all sections of each part of an exam required by the board. This will help us to ensure that Maryland licensees are required to provide high-quality optometric care that reflects current and emerging developments in education, training, and clinical practices. The bill removes the mandate that the board administer the Maryland State law exam, and the statute, as it's currently written, does not provide a specific length of time a license may remain in inactive status. This lack of a specific time frame for inactive status has really impacted on the board. And for example, currently 300 licenses have been in active status for at least 7 or more years. And many of these licenses may be abandoned, while others may not. Unless the board acts, all 300 of those licenses could potentially remain on inactive status indefinitely. The statutory amendment will clarify how long a license may be placed in inactive status and give the board authority to account for licenses that have been in inactive status for more than 6 years. Madam Chair and members of the committee, I would ask for a favorable report on Senate Bill 186, and got, like I said, members of the board here in support of legislation. Thank you.
Thank you, Senator. Nikki?
Hi, good afternoon, Madam Chair Beidel and Vice Chair Hayes, members of the committee. My name is Dean Gugerci. I'm a licensed optometrist, and I've been practicing for 14 years. Grew up in Annapolis and went to University of Maryland, practiced in Baltimore City, and opened my own office in Edgewater. I'm currently the president of the Maryland Board of Examiners and Optometry, and I'm here joined by Gwendolyn Joyner, our executive director. Thank you for the opportunity to testify in support of Senate Bill 186. Our written testimony has been submitted as requested. We're requesting the Finance Committee's support of SB 186. The bill amends language related to the board's licensing processes and procedures. Specifically, it removes old language that required the board to administer the jurisprudence exam, gives the board the authority to consider recent changes in the national licensing exam, and establishes an expiration period for inactive licensees, which is consistent with other health professions and boards. This bill will help the board carry out its mission to protect the public, ensure licensees are equipped and providing high-quality optometric care, and aid the board in promoting and maintaining high standards of care. It will allow us to streamline our processes and bring Maryland's regulatory framework in alignment with national trends in optometric education, training, and clinical practice. For these reasons, the Maryland Board of Examiners and Optometry respectfully requests a favorable report for SB 186. Thank you for your time and your consideration.
Thank you. Gwendolyn?
Hi, my name is Gwendolyn Joyner. I'm the Executive Director for Maryland Board of Examiners and Optometry. Good afternoon, Chair Beadle and Vice Chair and committee members. I'm here to answer any questions that you may have pertaining to SB 186 today.
That's it.
Answer questions. Okay. And I don't see any questions from the committee. So that was an easy bill hearing. Thank you, Senator.
That's why I was where I was. Thank you.
Next, we're going to hear from Senator Guile.
Thank you.
Senate Bill 88, State Board of Examiners for Audiologists, Hearing Aid Dispenser, Speech Language Pathologist, and Music Therapist. authority to issue limited license to practice music therapy. And Senator Gall, you're going to bring Nikki Runge up with you and Keena Stevenson, correct?
Thank you, Madam Chair.
Thank.
I think this one will be just as easy. Good afternoon, colleagues, Madam Chair, Mr. Vice Chair. For the record, Senator Dawn Guile here to present Senate Bill 88. This bill authorizes the State Board of Examiners for audiologists, hearing aid dispensers, speech-language pathologists, and music therapists to issue a limited license to practice music therapy and was filed at the board's request. This bill addresses a narrow but important gap in current law. The board already has the authority to issue limited licenses in other professions it regulates, allowing individuals who have completed their education and clinical training to practice under supervision while they finalize licensure requirements. Music therapists currently do not have access to a comparable pathway. Senate Bill 88 simply creates parity. It allows qualified music therapists to practice under the supervision of a fully licensed professional while they complete the certification examination. The bill includes clear guardrails, defined time limits, and supervision requirements, and it fully preserves the board's authority to oversee practitioners and enforce the Practice Act. This is a workforce and access measure, but it also is a patient protection measure. The limited license brings emerging practitioners under the board's jurisdiction, ensuring accountability and oversight during their transition to full licensure. You will hear from Nikki Runge, a licensed music therapist who can speak to the real-world impact of this bill and why a supervised pathway into the profession matters for both providers and patients. And we also have Keena Stevenson, who is here just to answer questions from the Maryland Department of Health. And with that, I respectfully request a favorable report on Senate Bill 88.
Thank you, Senator. Who's next, Nikki?
Yes. Good afternoon, Madam Chair, members of the committee. My name is Nikki Runge, representing the Board of Examiners for Audiology, Hearing Aid Dispensers, Speech-Language Pathologists, and Music Therapists as a music therapy member of the board. The board is asking for a favorable report to SB 88 for the authority to issue limited licenses for music therapists. The clinical training process for music therapists includes a minimum of a bachelor's degree in music therapy from an accredited institution, followed by a clinical internship that culminates in 1,200 hours of supervised clinical experience before being able to take the National Board Certification Exam through the Certification Board for Music Therapists. Nationally and historically, interns have been eligible for employment with the requirement that board certification be obtained within a specified amount of time after completion of their internship. However, in states with licensure, there is no such access to employment. So it can delay employment. It can delay there is increasing demand for music therapy in Maryland. It delays the access to services for vulnerable populations. As was previously stated, that all of the other disciplines under our board have a limited license. So we are just asking for consistency across the board disciplines. And I would welcome any questions that you may have.
Thank you. Let's hear from Keena next, and then we'll see about questions.
Good afternoon, everyone. Keena Stevenson, Executive Director of the Board of Audiologists. And just to piggyback on what Nikki said, a very important part of this bill, it will allow current students in the music therapy field to work while finishing up our requirements. Each discipline on our board does offer the limited licensure, so this would fall in line with our current practice. And it also comes with zero fiscal impact or any operational impact. So again, the board is requesting a favorable report, and I can answer any other questions that you may have.
I'm looking for questions. I have one question. Have they already taken the exam before they do serve the hours?
Sorry.
No, once they have finished the 1,200 clinical supervised hours, then they are eligible to take the exam. So this would just, the limited license would be to fill in that time gap, because once, if somebody takes the exam and they don't pass it, they have to wait 30 days to take it again. And so there's no system in place right now for interns to be able to go into the workforce under the supervision of a fully licensed practitioner while they are trying to pass the exam.
We have some other licensure issues that I'm trying to compare. Thank you.
Got you. I understand.
Thank you, Madam Chair. Yes. Hi. Oh, I brought the wrong book. Sorry about that. I don't think you all want to hear about the conversion to lead ammunition.
We've already
Away
had
from lead ammunition.
that issue once today with the wrong bill, so thank you.
I had 3 bills, so I'm juggling notebooks. Good afternoon, Madam Chair, Mr. Vice Chair. I guess he stepped out. Members of the committee, good to be back here this year with my first bill before you. SB 240 establishes a stakeholder advisory council for OHCQ. I assume you all know what that is, but some people don't like acronyms, so Office of Health Care Quality. So why are we bringing this bill forward? Many of you are familiar with the background. Maryland, unfortunately, has had a history of challenges in providing sufficient regulatory oversight of our healthcare facilities, including hospitals, nursing homes, and adult daycare. Maryland has had a decade of the longest emergency room wait times out of all 50 states. Over 100 nursing homes going without required annual inspections for 4 years. We were ranked second to the worst in the United States in annual inspections of nursing homes. Last autumn, there were 2 articles in the Washington Post about OHCQ failures. 20 out of 20 adult daycare centers failed surprise inspections by CMS, and an alarming increase in medical errors in Maryland hospitals. So what would this bill do? It establishes a stakeholder advisory council that would provide constructive feedback to OHCQ from a very diverse group of stakeholders. The council will be non-regulatory, a forum that will promote engagement and transparency, identify opportunities, address concerns, and build trust and communication with the Maryland public. The Stakeholder Advisory Council is modeled on a very highly successful federal advisory committee that has been established across the government. For over 5 decades, federal government agencies have relied on their advisory committees for thoughtful advice, guidance, and support. This model has proven to be effective in federal agencies, and we believe it can work at the state level as well. So the council chair would be selected by the director of OHCQ for a 2-year rotating term. It's important that the director chooses the chair so that they have strong connection and communication with the advisory council. The council membership would be very broad-based. Frontline hospital workers, nursing home care workers, representatives from long-term care, the industry, state legislators, and government agencies, such as the Office of the Secretary of Health
and the Secretary of Aging. So in total, there would be 22 council members. At council meetings, OHCQ will be asked to provide updates on metrics from the past 6 months, including number of hospitals monitored, number of nursing homes inspected, number of complaints received, length of time for OHCQ responses to complaints, number of code violations identified by OHCQ, and number of complaints resolved. And the chair, of course, would be free to add other agenda items. The formal council meeting will include a period for public comment. The chair would write a summary report, which is not necessarily a consensus document, just a summary report that would include stakeholder feedback and would be posted online. The council will also flag any issues of negligence in provision of oversight by OHCQ to the Secretary of Health. The council will meet virtually twice a year and incur no costs. The time commitment for 2 meetings a year would be approximately 2 to 3 hours per meeting. Advice from the Stakeholder Advisory Council will be non-binding. Instead, it would provide the opportunity for dialogue and helpful advice from diverse stakeholders to OHCQ. Improved communication always promotes engagement and transparency and helps to improve the quality of healthcare in our state. As I mentioned, the federal government has been using this model since 1972, over 50 years. Currently, it's being used in about 50 agencies. Over 900 stakeholder advisory councils are in use across the federal government. But I want to mention, this is not a concept that is unique to the federal government. I'm going to give you an example of one in the private sector. In my former life, one of the positions I held was Director of Card Member Services for American Express. Probably one of the most significant accomplishments that my department put forward was establishing the Centurion Council. They were the eyes and ears of card member service delivery. And you may have heard or read, American Express has a pretty good reputation for card member service delivery. There are just some things you can't learn in quantitative research, and hearing actual experiences gives you a whole new lens as to identifying problems early and identifying the most common problems. So I do want, in closing, to respond to a few concerns that I read in the opposition testimony. Standing advisory committees, as I mentioned, are common in government, in industry, in healthcare, and they provide helpful advice and feedback to executives. You're going to hear Dr. Palmisano about her experience with longstanding and highly successful federal advisory committees. Moreover, Johns Hopkins has 8 standing patient family advisory councils at their hospitals with a total of 200 members, or approximately 25 council members per hospital. The bill clearly states that the advisory council will provide feedback from stakeholders regarding maintaining oversight of healthcare facilities. That means any or all of the 47 facilities can receive advice and feedback from the advisory council as needed by OHCQ to improve function. At each public meeting, data reports from hospitals and nursing homes are specifically called out twice in the bill language, simply because of the numerical abundance of patients using those types of healthcare facilities. This council will also have membership very broad, as I mentioned, and diverse, including healthcare workers, patient advocates, industry representatives, and 2 state government officials, 1 from each chamber. An employee of the Department of Aging once expressed some concern that this council might have some overlap with the Department of Aging Oversight Committee on the quality of nursing homes and assisted living. Dr. Palmisano created a Venn diagram, which I believe is an attachment to her written testimony, and it really illustrated this concern. In her diagram, she showed this particular Department of Aging employee that, in fact, there was no significant overlap in either the purpose, membership, or responsibilities of the advisory council that we are recommending today. Concerns about negligence by OHCQ in maintaining oversight of healthcare facilities may be raised during advisory council discussions. Given that the Secretary of Health or her designee would be part of the discussions in the advisory council, that information will be imparted in real time during the meetings. Using tools of modern, and I'm now getting into the timing and the fiscal note issue. Using the tools of modern technology, the advisory council will not increase OHCQ workload in any significant way. The meetings are held virtually. AI can be used to take notes and summarize discussions. The data that are requested OHCQ are already tracking and preparing regarding productivity. So more ideas from the advisory council might actually help improve new efficiencies and opportunities to enhance productivity. We did do an estimate of time required. Dr. Palmisano took a stab at it. I did as well. Also in my prior life, I worked for a consulting firm. We had to provide potential clients with estimates of how many resources, financial and human, that a project would take. And if our estimate was more than 15% or more than 15% under estimate, we had to eat those costs. So our estimate of the workload of this committee or this advisory council is something like 8 to 16 hours, not a full-time employee. I think we've seen faulty fiscal notes before. This one may take a new prize. In summary, only de-identified aggregate data needs to be presented, which doesn't create any privacy or confidentiality issues. There are a number of good reasons to try to establish this committee to be our eyes and ears to earlier detect issues with OHCQ and our health facilities. Thank you for your time and attention. I now pass it on to my panel.
Madam Chair, Vice Chair, and committee members. I'm Dr. Anna Palmisano. I'm the Director of Marylanders for Patient Rights. We're the largest patient advocacy coalition in the state with 23 groups with a collective membership of over 1 million Marylanders. The Stakeholder Advisory Council for OHCQ will help to improve that vital oversight function and the quality of care. SB 240 is also part of the 2026 Caring Across Maryland legislative agenda, and you'll be hearing more bills from that agenda later on. By now, I'm sure you're all aware of how Maryland has ranked among the worst in so many key parameters: ER wait time, hospital patient satisfaction, timely nursing home inspections, the numerous violations in adult daycare, and medical errors, including fatal ones, that were reported in the Washington Post this fall from a Maryland Department of Health report. So the Stakeholder Advisory Council, it will help OHCQ by providing diverse perspectives, constructive feedback, improve effectiveness, and help to restore public trust. Everyone has a stake here in wanting to make sure that OHCQ is regulating our healthcare accurately. The council, as Senator Lewis Young has mentioned, it's modeled on the senior executive advisory committees across the federal government. It's actually based on a 1972 Federal Advisory Committee Act, as Senator Lewis Young mentioned, across federal agencies. My experience was I was a senior executive at the U.S. Department of Energy, and it showed me that the standing advisory councils were very helpful in providing leaders like myself with thoughtful advice, guidance, and support. And this has proven, am I done?
Finish your sentence.
You can finish your sentence.
Well, it has proven not only in federal agencies, but also the state of Massachusetts in 2023 has used a similar model. Thank you very much, and I hope you have a favorable report for SB 240.
Good afternoon, Chair Vidal, Vice Chair Hayes, and members of the Senate Finance Committee. Thank you for the opportunity to testify in support of Senate Bill 240, which seeks to establish the Stakeholder Advisory Council to support the work of the Office of Healthcare Quality, or OHCQ. My name is Sarah Westrick, Advocacy Director for AARP Maryland, and I'm here today representing our approximately 850,000 members in the state. We thank Senator Lewis Young for sponsoring this important legislation. OHCQ plays a vital role in overseeing the quality of care provided in our state's healthcare facilities. This bill takes a crucial step toward enhancing OHCQ's effectiveness by creating a stakeholder advisory council that will provide valuable feedback and recommendations to the office. The council, comprising diverse stakeholders such as hospital workers, industry representatives, and advocacy groups, including AARP Maryland, will bring a wealth of knowledge and expertise to the table. By periodically engaging with these stakeholders, OHCQ will gain a deeper understanding of the challenges and real concerns faced by healthcare providers, patients, and families, ultimately leading to more informed decision-making and better outcomes. In addition, holding virtual public meetings every 6 months will provide opportunities for public comment, and this will help build transparency and accountability. It will also foster trust among the stakeholders and provide a platform for the public to share their concerns and experience. We believe this is essential for driving meaningful change. We believe SB 240 has the potential to significantly improve the effectiveness of OHCQ and ultimately the quality of care in our state's healthcare facilities. AARP Maryland respectfully urges a favorable report on SB 240. Thank you for your time and attention.
Thank you. One more.
Good afternoon, Chair Vidal and members of the committee. My name is Tamlin Kelly, and I'm here today on behalf of Disability Rights Maryland to express our strong support for Senate Bill 240. OHCQ has an essential function of ensuring that all of us are safe when we receive healthcare services. While the responsibility entrusted to OHCQ is great, there's too little public oversight of their work. We expect that this bill will increase transparency, will improve the timeliness of investigations, and will ensure the effectiveness of the process to correct problems that have been found in facilities. Disability Rights Maryland is still waiting for OHCQ to investigate 4 complaints that we sent in 2021, including complaints about the improper use of chemical restraint and about alleged abuse of a patient by a staff person. In 2022, Disability Rights Maryland sent a complaint about illegal prolonged seclusion of people with disabilities occurring in a Maryland hospital. OHCQ did not investigate this complaint for several years until we resubmitted an updated complaint last year with the same concerns. We later learned that in 2023, while we were waiting for that investigation, 12 people spent more than 700 days in prolonged seclusion. This included one man who spent 322 days, mostly the entire year, in prolonged seclusion. When an OHCQ investigation finds that a facility is violating regulations, they develop a plan of corrections to address them. However, too often the investigations cite the same repeated findings. Repeated findings have even been cited in investigations of patient deaths. Examples include a hospital that's their medical staff lacks current CPR certifications and a lack of hot water in a hospital. The new advisory council will help to ensure that when OHCQ finds dangerous conditions, we can be sure that the facilities are closely followed until the conditions have been resolved. For these reasons, we urge a favorable report.
Perfect, thank you. I think I see Lorraine. You didn't come up to the table yet, but you're welcome to come up, Lorraine. And then we'll do questions after that. Thank you.
Good afternoon, Chair Beidel and members of the Senate Finance Committee. My name is Lorraine Aricott. I'm the Senior Policy Analyst with 1199 SCIU, proud representation of healthcare workers across the care continuum from hospitals to nursing homes. We support SB 240 alongside the Caring Across Maryland Coalition because in a time where we are experiencing devastating healthcare cuts, it is of the utmost importance that we work to uphold quality of care and hold healthcare facilities accountable. It has always been patients and healthcare workers and caregivers and family members sounding the alarm when facilities make decisions that diminish quality of care. Our nursing home members know that in Maryland, our nursing homes are experiencing a churn of new owners. And with each change, the first decision owners make is to cut staff, leaving facilities understaffed to care for Maryland's most vulnerable aging seniors who need more care. As a Baltimore constituent, it's also alarming to see the number of known unlicensed assisted living facilities operating and the number of calls coming from families and caregivers that reveal one thing, that people in their final years are living in unreasonable, unfathomable conditions while government agencies look away. The Office of Healthcare Quality is responsible for monitoring and licensing the state's healthcare facilities and says it takes the appropriate actions to protect seniors, but acknowledge that despite hundreds of complaints since October 2023, it has only sent for one referral for prosecution to shut down an unlicensed assisted living. This bill would restore public trust and transparency, include all relevant stakeholders, and lay the foundation for open dialogue and problem solving within OHCQ. And for those reasons, I urge a favorable report. Thank you.
Thank you, Lorraine. Now, I have questions. I'm not sure who was first. Senator Reedy?
Thank you, Madam Chair. I was curious, Senator Lewis Young, what has OHCQ's response been to this legislation? I notice they're not testifying.
We did have a number of meetings with them. Actually, I'll let Anna.
Senator, will you pull the microphone closer, please?
I'm going to ask Dr. Palmisano to respond because she was involved with more of the meetings with OHCQ than I was.
Yeah, we met with the current director, Tia Witherspoon, and a number of her colleagues from the Maryland Department of Health, and they were pretty quiet about it. They said they were going to send it up their food chain and talk to some other peoples, but we didn't get other leaders in their group, but we didn't really get a sense one way or another of how they were going to, whether they were going to support this or not. I understand there is written testimony by OHCQ expressing concerns about workload and money, and I feel that we've addressed those concerns. In fact, we did in that particular meeting.
Yeah, just because I would tell you, I am really grown concerned about the unlicensed nursing home issue because we've even passed legislation to try to get a handle on it, and it's just not being enforced. And I'm not sure if the bill, there might be some tweaks to it. I don't know. Yeah. But I know that's not the only issue that this commission would look at. But to me, everybody's going to say we're understaffed, we don't have the resources. The most important thing is we've got to get a handle on these illegal operators that are taking seniors' money, or and just basically like warehousing them. And our licensed operators generally, while I'm sure there are issues that come up, do a good job. They follow the law. But probably, you know, I understand there's a desire for more inspections there too, but I've just really, the more I hear about it, and it's not just, it's gotten reported a lot about it being Baltimore, but there are ones I'm told in my jurisdiction and in our shared jurisdiction, Senator Lewis Young, and it's just, we got to get to the bottom of it. I'm you know, I have not seen the sense of urgency from OHCQ that I feel like there should be when this story is out there. So we need to take that seriously. Isn't that so, is my final question.
Yeah. Do you want to answer that, Senator Lucien?
Well, we had another experience which probably precipitated this. I think you remember this bill. Well, it was around 2017, 2018, the Patient Bill of Rights in hospitals. Took us about 3 years to bring that forward. But after the bill passed, we tried to monitor with mystery shopping and talking to constituents whether it was being enforced. And we found out not, and tried to follow up to say, why aren't you implementing the bill as written? Why? And, you know, we basically did not get the right answer.
Yeah.
Thank you, Senator. Senator Kramer?
Thank you, Madam Chair, and I want to thank the bill sponsor and all of you for this legislation. I think it's incredibly important. I have been absolutely astonished and dissatisfied with OHCQ over the past several years. The level of failures that OHCQ has been responsible for with regard to our assisted living facilities, our nursing homes, and the full range of healthcare facilities for which they have responsibility has just been astonishing. And I have to believe that with this having eyes on OHCQ, if we had done that in the past, we may not have gotten to the point where we have completely failed the most vulnerable in our communities, and that's where we are right now. And I have to say that even with what I believe is still a questionable fiscal note as to you know, the amount put in, and we all know death by fiscal note is always a strategy. But even at that value that it's shown, that is more than a worthwhile investment to ensure that we have independent, and that's going to be critical, independent eyes on OHCQ. I'm a little bit concerned that OHCQ is going to be appointing the chair or whomever that individual will be, and maybe there's a chance to rethink how that might happen, because there will have to be total independence from the Department of Health, from OHCQ, to ensure that this group is able to see what's going on and report back to us, because I can tell you what I learned over the last couple of years is that OHCQ, whenever they could, made misrepresentations to this committee and to our sister committee over in the House, and it was not accidental. It was done intentionally, and I have to believe it is more than time to ensure that we have some oversight as to what's going on there, because otherwise we don't learn of the fact that Maryland has either been tied for dead last or second to dead last in our nursing home inspections. We have no clue how bad it is in our assisted living facilities, but we can assume that if we've been tied for dead last or dead last in nursing home inspections, we're not doing any better in that category. And I think it's important that we start getting some feedback from an independent source rather than from the source, because they will do their best to mask their failures when meeting with those of us here who are in fact responsible at the end of the day for what's happening to our residents. So thank you for this, and I look forward to its passage. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions for this panel. We have another panel of favorables. We have Megan Peters, the Alzheimer's Association, Roxanne King, American Association of University Women, Ann Geddes, Mental Health Association of Maryland, and Brooke Roschheim, Marylanders for Patient Rights. Someone can begin, please.
Good afternoon, Madam Chair, members of the committee. My name is Megan Peters. I'm here on behalf of the Alzheimer's Association in support of Senate Bill 240. We support this bill because Maryland needs the regular, transparent way for our stakeholders to engage with OHCQ about how facilities are being overseen. People living with dementia are among the most vulnerable residents in our care settings, and many can't report concerns themselves, which makes strong state oversight essential. Unfortunately, we've seen what happens when oversights break down. The consequences for people with dementia are very real: preventable injuries, untreated medical conditions, or unsafe wandering. The state has been working to address these lapses in oversight in recent years, and we appreciate that progress. But after these years of issues, we need a regular way for our stakeholders to stay engaged and help prevent these failures moving forward. SB 240 provides that ongoing engagement, bringing transparency, accountability, and collaboration to the forefront, and improving safety for some of our most vulnerable Marylanders. For these reasons, we urge a favorable report. Thank you.
Hi, I'm Ann Geddes with the Mental Health Association of Maryland, here in strong support of Senate Bill 240. We're particularly concerned people with serious mental illness are especially negatively impacted by poor quality nursing homes. About 20% of the people who reside in nursing facilities are people with serious mental illness. And multiple studies have shown that those facilities that have a significant number of people with serious mental illness are in facilities that provide much worse than average care. The failures of OHCQ over the last decade to adequately inspect nursing homes and investigate complaints, they're well documented. New leadership has brought about some positive change, and the legislature took action last year to bring about some positive change. SB 240 would further enhance protections and oversight of OHCQ. It would again, a group of stakeholders who could not only just oversee the work of OHCQ, but could provide feedback, make suggestions. We know that people with serious mental illness in nursing facilities are not getting the psychiatric care they need most of the time. They could receive feedback on some of the things that might be done to address that issue. So for could report to the legislature the findings, could report to the Secretary of Health findings and any concerns that need to be addressed. So for these reasons, Mental Health Association supports SB 240 and urges a favorable report. Thank you.
Good afternoon, Chair Beidel and Vice Chair is not here, okay, and members of the committee. I'm Roxanne King, and I'm representing AAUW, the American Association of University Women of Maryland, and also I'm the president of the Anne Arundel County branch. We are a group of aging women. We have young women, but I would say 75% of our members in the state are seniors, okay? And health care is very important to us. And what is happening to our healthcare system is important. And we're asking your support for SB 240. We need oversight of the Office of Healthcare Quality and would like the community to be a part of what's going on there, and we need transparency for what's going on in our healthcare system. We want to be able to look forward to care for all of our seniors. Thank you very much, and please support.
Chair Bidle, Vice Chair Hayes, and members of the Senate Finance Committee, thank you for the opportunity to testify. My name is Dr. Brooke Rossheim. I'm a Maryland licensed physician, board certified in public health and preventive medicine and internal medicine. I'm the senior medical advisor for Marylanders for Patient Rights, and I'm here in support of Senate Bill 240. For years, there have been concerns that the Office of Healthcare Quality has failed to conduct required nursing home inspections on time and has not addressed resident complaints within mandated timeframes. This simply puts patients at risk. SB 240 offers a thoughtful and practical solution. First, it establishes a stakeholder advisory council comprised of frontline staff, a physician, healthcare administrators, and external stakeholders. The idea that this bill overlaps with the Maryland Department of Aging Oversight Committee on Assisted Living and Nursing Homes doesn't really tell the full story. OHCQ has a far broader focus than just care for older adults in assisted living facilities and nursing homes. Finally, the council is advisory only. It doesn't regulate OHCQ, but provides informed recommendations. For these reasons, I respectfully urge a favorable vote on SB 240. Thank you for your time and consideration.
Thank you very much. I don't see any questions for this panel, so thank you very much for your testimony. We have one unfavorable, Dana Kaufman.
Good afternoon, Madam Chair, members of the Senate Finance Committee. For the record, my name is Dana Kaufman. I'm here on behalf of three organizations, Lifespan, the Maryland National Capital Home Care Association, and the Maryland Association for Medical Adult Day Services. And before I begin my testimony, I want to be very clear that we recognize that there are very serious issues that need to be addressed, especially dealing with the unlicensed businesses. And I'm going to call them unlicensed businesses because I think it disparages the licensed assisted living providers who work very hard. And we look forward to working with you on those issues. Lifespan does have a lot of ideas that we hope that we can bring to the table. However, for today's hearing, the concerns that we're raising are really just on the four corners of this document and what it says and what it doesn't say. So, for example, we are very concerned that the scope of the bill is unclear. On page 2, lines 7 to 8, it specifically states that the advisory council shall provide feedback to the office regarding maintaining oversight of healthcare facilities. There are 47 healthcare facilities or programs that the Office of Healthcare Quality regulates. However, if you look further in the bill, on pages 4 and 5, it restricts the focus to only hospitals and nursing homes. And this is very important because the scope is going to dictate the membership. And if it's only nursing homes and assisted living, nursing homes and hospitals, then again, we are concerned about the duplicative nature of the Oversight Committee on Quality of Care in Nursing Homes and Assisted Living. However, if it is broader, then the membership does not take into account the voices of those other programs and services. For example, medical adult day, home care, and the other 45 industries. So I think we really have to tailor what this bill is trying to do. And again, we're very concerned about overlap and duplicative nature. Just the last point, also be aware that the advisory council is to notify the secretary if the office is negligent. And that is a very big mandate. And I think we need to also focus on that. Thank you very much.
Thank you, Dana. I don't see any questions. Thank you for your testimony. We have one virtual, Ruth Carlock, Brain Injury Association of Maryland, and it's virtual. Ruth, you can go ahead. Ruth, you can go ahead with your testimony.
Okay, thank you. Good evening, everyone. My name is Ruth Carlock, and I represent the Brain Injury Association of Maryland, and I'm here in support of SB 240. This bill would collect a diverse team of Maryland's healthcare leaders and designated politicians with frontline hospital workers, nursing home workers, healthcare advocates, and those in the care of these organizations several times a year to complete a public meeting to develop recommendations to improve the quality of nursing home and hospital care in Maryland. This change would add greater public feedback and accountability to the process, with public meetings focused on reporting the number of hospital monitoring, nursing home inspections, hospital patient complaints, and code violations. With these biannual meetings helping build trust that has been lost by this ongoing issues in these among these healthcare industries. According to the data from 2024, Maryland currently has the longest wait times in the country, with some Marylanders driving out of the state for emergency hospital care. Nursing homes have seen a consistent decline in quality among those living in a nursing facility as more people are needing care, with the needs of services only increasing over the coming years with a rapidly aging retirement population. Currently, the Office of Healthcare Quality has been seeing issues keeping up with demand for improving healthcare quality, and this bill will help return the vital oversight function to improve the declining quality of care in Maryland. As a case manager for the Brain Injury Association of Maryland, my clients come directly from the nursing homes and hospitals, and a client recently I've been working with for years, after being placed in a nursing home, has experienced huge neglect, minimal oversight, and a lack of transparency in getting information to his healthcare teams and family. Their issues are we see pretty frequently among TBI survivors and their advocates, many desperate to get them out of these nursing homes, unable to meet their complex demands. Given the ongoing healthcare quality challenges in Maryland, the establishment of the Stakeholder Advisory Council is a necessary step in providing constructive feedback and advice to push healthcare in the right direction. We ask that you render a favorable report for Senate Bill 240. Thank you.
Thank you for your testimony. Do I have any questions for this witness? Seeing no questions, that ends the hearing on Senate Bill 240, and we're going to go on now to Senate Bill 260. Our own Senator Carl Jackson is the sponsor, Maryland Healthcare Commission, and Natasha Mayhew is on his panel, I think. Let me see Natasha. There she is. Just give her a second to get to the table, Senator. Thank you.
All right. Good afternoon, Chair Bidle, Vice Chair Hayes, fellow members of the Senate Finance Committee. For the record, I am Senator Carl Jackson here to present Senate Bill 260, Maryland Healthcare Commission membership. This legislation updates the membership of the Maryland Healthcare Commission by adding a designated seat for the hospital administrator. This bill will help ensure that MHCC commissioners better represent the broad range of key healthcare stakeholders in Maryland. The Maryland Healthcare Commission is an independent state regulatory agency that helps oversees Maryland's healthcare system, including planning and evaluating healthcare access and performance, and managing programs that regulate guide the development and delivery of health services. MHCC monitors healthcare costs and market dynamics, conducts data-driven analysis of provider and insurer trends, and administers regulatory programs that govern the development of health facilities. For example, the MHCC oversees the Certificate of Need program, which reviews and approves new hospital bed capacity and major health service changes. MHCC plays an important role in ensuring that hospital services are accessible, high quality, and aligned with the state of Maryland's long-term healthcare system goals. While nursing home physicians and health insurers have designated representation on the MHCC, hospitals do not. Maryland hospitals and health systems are a critical part of Maryland's healthcare system and work directly with the MHCC on facility planning, service approvals, and data reporting and the system performance assessments. As hospitals and healthcare systems are deeply involved in these regulatory and planning processes, it is appropriate that they also have a formal voice in MHCC decision-making. SB 260 ensures that hospitals and health systems, as a vital part of Maryland's healthcare system, have a seat at the table. MHCC has reviewed the legislation and asked that we make one small technical amendment on page 1, line 6, and page 2, line 10. The amendment replaces the word representative with the word administrator. This is for the sake of consistency in the statute. I respectfully request a favorable report on SB 260 as amended. Thank you.
Good afternoon, Madam Chair, members of the committee. I'm Natasha Mayu here on behalf of the Maryland Hospital Association in support of Senate Bill 260. This is a MHA legislative priority, and we do thank Senator Jackson for sponsoring the bill on our behalf. As you heard, the bill is very straightforward, simply adding a hospital administrator to the MHCC. MHCC plays a broad and important role overseeing Maryland's healthcare systems. The regulatory programs and policies shape how health services are developed and delivered across the state. As Senator Jackson mentioned, they oversee certificate of need, so whether a hospital can open and how many beds they can have. But they also regulate CRISP and protected health information, governing how healthcare information is shared, stored, and protected. And so hospitals are directly impacted by their actions and policies. And as is noted, while insurers, nursing home administrators, and physicians have dedicated representatives on the commissions, hospitals do not. Hospitals have an important perspective to share, given the unique nature of Maryland's hospital model and operations. Importantly, MHCC is neutral on the bill. We did consult with them as we drafted the bill. As was noted, we put forward a technical amendment at their request. So we thank them for engaging with us, and for all these reasons, we urge a favorable report on Senate Bill 260.
Thank you. I do have a question. I don't know if you're going to change this with one of your amendments, Senator, but it says one shall be a representative of a hospital, and then as defined in 19301. Is that where we get to the administrator? Doesn't say it should be an administrator of a hospital.
The request for the administrator was on behalf of MHCC because the nursing home is labeled as a nursing home administrator.
The council just showed me the amendment that I can't see in line yet, so thank you. Any other questions? Seeing no questions, that ends the hearing on Senate Bill 260. And now, Senator Jackson, you're going to do Senate Bill 293, professional liability insurance coverage, nursing homes, assisted living facilities, and nurse midwives disclosure. And I think you have Emily Malarkey from the Maryland Association for Justice, Michael Rubin, Dr. Staten, Goldberg, and Cardia, Ashley White. No, she'll be virtual. We'll get to her in a minute. Mickey Pastrikas from Myers, Robel, and Rosenbaum, and Carrie Craig from the State Long-Term Care Ombudsman.
No, we're good.
I think you're short one. Here we go. Okay. Senator, you can begin when you're ready.
Thank you. Good afternoon, Chair Bidle, Vice Chair Hayes, fellow members of the Senate Finance Committee. For the record, I am Senator Carl Jackson here to present Senate Bill 293, professional liability insurance coverage, nursing homes, assisted living facilities, and nurse midwives disclosure. In 2017, a General Assembly considered legislation that would have mandated professional liability coverage for Maryland physicians. Although efforts to require malpractice insurance did not pass, what this body decided on instead was a law that required physicians to notify their patients if they chose not to carry insurance. As passed, that law does three things. First, that law requires uninsured physicians to notify patients in writing about the fact that they do not have professional liability insurance, or if their insurance had lapsed. Second, the law requires an uninsured physician to obtain the patient's signature on a written notification and to maintain that signed document as part of the patient's medical record. Finally, the law requires that the uninsured physicians post information about the lack of insurance coverage in a conspicuous location in their place of practice. Of course, The goal of this law was to encourage physicians to obtain professional insurance coverage in the first place. But just as important, it was meant to educate otherwise unknowing patient consumers about the fact that their physician may not be properly protected. 2 years ago, in 2024, the General Assembly extended these same requirements to nurse practitioners who chose to practice without liability insurance. That legislation passed the first year it was introduced with a unanimous favorable vote in this committee and in the House Health and Government Operations Committee, as well as unanimous votes on the floors of both chambers. SB 293, the bill that brings me before you today, extends this law again, this time to midwives, nursing homes, and assisted living facilities. As you are about to hear from the witnesses on this panel, the unfortunate truth is that a number of Maryland nursing homes and assisted living facilities, especially small privately owned assisted living facilities operated out of private homes, do not carry liability insurance. The same is true for a number of nurse midwives who practice in the home setting or outside of a hospital or established medical practice. As this body has already recognized on 2 prior occasions, part of an adequate patient-informed consent involves a healthcare provider advising their patient if they are not protected by liability insurance. By professional insurance. This is especially true for vulnerable elderly patients entering a nursing home or assisted living facility, and for pregnant patients who choose a nurse midwife as their primary provider. By mandating clear and timely notification about the lack of insurance for these healthcare providers, this bill empowers patients and residents to make informed decisions about their care and continues the public policy goals that have already been established by the General Assembly in the past for other healthcare providers. I respectfully request a favorable report on SB 293. Thank you.
Yes, good afternoon, Chair Bidle, members of the committee. My name is Emily Malarkey. I am this year's legislative chair for the Maryland Association for Justice. Professional liability insurance serves as a critical safeguard, protecting patients from malpractice and ensuring that caregivers are financially accountable for their actions. Although we would all love it if all healthcare providers carried liability insurance, as you are about to hear from my panelists, and as you can read in some of the written submissions that have been submitted by others, that simply isn't the case. Professionals who don't carry liability insurance are essentially judgment-proof. It's shocking for our clients, innocent injured patients, to learn when they consult with an attorney that nothing can be done and that there are no consequences to even the most egregiously negligent conduct or neglect. The next best thing to this body requiring liability insurance is to educate patients and their families about the lack of insurance on the part of the trusted healthcare provider, so the patient or their family can make an educated choice before placing their trust in the provider. This body has already recognized that Maryland patients and their families have a right to be advised of the lack of professional liability insurance when they select a physician or nurse practitioner, and we ask you to extend those same protections to nursing homes, assisted living facilities, and nurse midwives. By doing so, this bill not only empowers patients and residents of these facilities to make informed decisions about their care, but it continues this body's laudable goal of creating a deterrent effect, encouraging these providers to obtain insurance in the first place. The Maryland Association for Justice supports transparency between healthcare providers and their patients, and the public policy goals this legislature has already recognized before on 2 occasions. We urge a favorable report on SB 293.
Good afternoon, members of the committee. My name is Mike Rubin. I'm an attorney at Shakur Estate and Goldberg in Cardia in Baltimore. It's a privilege to speak in support of this bill. About a year ago, I had the honor of representing a Maryland family who experienced the worst thing that anyone can possibly imagine, the loss of a child. The parents hired a midwife whom they assumed carried professional liability insurance. This midwife assured them that it was safe for them to have a home birth, even though the mother had previously had 2 deliveries via C-section. I will spare you the details of that delivery, but you must know that the patient suffered and ultimately the child passed away. The baby's name was Nayeli Lewis. And this photo is a picture of her saying hello and goodbye to her family. And it was taken just up the road here in Anne Arundel County. My firm took this case and we saw it through to the end, even when we knew a recovery was unlikely. We did that because that was the right thing to do for Nayeli. This family, these terrific parents, would have never elected to retain this midwife had they known she did not have professional liability insurance. This bill will ensure that other Maryland families are not left in the dark until it's too late. And when the worst happens, it will preserve a family's ability to seek accountability. For Nayeli and for every Maryland family who deserves transparency and accountability, I urge you to pass this bill. Thank you.
I see a question from Senator Goff.
Thank you, Madam Chair, and thank you, Senator, and everybody on the panel for their testimony. So, I mean, obviously, there's two very sort of different things. There's assisted living, there's a nursing home, and then there's nurse midwives, right? For one, I guess my question is, does it say anything about what the content of the notification must look like?
It does not. It's the language of this bill tracks the language that was enacted in 2017 and 2024 for the other two categories of providers.
Okay.
So it says that informed consent must be provided to the patient, that the provider either does not have insurance or the coverage has lapsed, and that the patient must sign, and that document must be kept in their medical record, and that it must be posted conspicuously in the place of practice, that there is no insurance. There's no language.
Okay.
Directed.
And if it says informed consent, I sometimes don't know if patients really know what that means. If somebody doesn't have professional liability insurance, what that could ultimately mean for them. So that's why I ask whether, like, the exact content. My other question is, so with respect to nurse midwives, is this applicable? I mean, I think the awful situation you may be describing was that was a home birth, right?
Yeah, our mom is the next testifier.
Okay.
So
yeah. But is this applicable also to? I mean, there's like certified nurse midwives that work out of like practices, hospitals, and other type settings versus those midwives that may work, I guess, sort of independently, maybe doing home births and otherwise. So is this applicable to all? I mean, I guess I would assume that those that are associated with the hospital probably likely almost have, but so but is this applicable to all nurse midwives?
it is, but you hit the nail on the head. The problem is not the practitioners that are in a hospital, because in order to have privileges to work at the hospital and be employed by the hospital, they're either covered by the hospital's liability insurance, or they have, as a matter of having privileges at the hospital, they have to have malpractice insurance.
Okay.
It's not those practitioners that really are the target of this bill. It's the assisted living facilities that you all were talking about with the previous panel. It's nurse midwives that are seeing patients outside the context of an established medical practice or hospital. Those are the ones who, typically speaking, are the offenders of not having the insurance in the first place, and the ones this bill is designed to address.
Okay, thank you. And my last question, I don't see, when I'm looking at the bill file and the list of organizations and individuals who've submitted testimony, I don't see anything from the midwives. Has there been any conversations with them from their organization?
I thought that we had, I have to check and get back to you about that. I thought that we did have a conversation with them, and I thought, it was my understanding, they were going to be supporting the bill. If they didn't submit something, obviously that's not public yet, so we wouldn't know, but I'm sure Senator Jackson's office would know.
Yeah, we can check on it.
Yeah.
Okay, all right, thank you. Thank you, Madam Chair.
Thank you. I want to ask a question to the attorney, Mr. Rubin. I don't want to ask this to the mom. We've had bills before that we should allow vaginal birth after cesarean, and we've never passed that bill. So what this midwife did was against Maryland regulation. Is she still practicing as a midwife?
I'm happy to report she's not.
Okay, I appreciate that. Thank you very much. So you have a panelist virtually, and it is Ashley White. So Ashley, if you'll unmute, you can go ahead.
Hi, thank you for your time and attention to this extremely important issue, and I would like to thank all of the individuals that worked to put this bill together. My name is Ashley White, and I speak on behalf of not only myself, but my daughter Nayeli. Her name is from the Zapotec language of the Oaxacan people and translates to "I love you." She would have been 3 years old this April. Instead of helping her pick a theme for her birthday, I'm here speaking with you in support of SB 293, a crucial defense for an individual seeking supportive care. Nayeli was lost to us because I was without my fundamental right to informed consent. There currently exists a dangerous transparency gap wherein my midwife comfortably sat, existing outside of what I believe to be a necessary part of a checks and balance system that keeps patients and their families protected. Had this person been required to tell me they were not insured, I would have made a different decision for where to place my trust. And I would have put my daughter's life in someone else's hands. Instead, my daughter did not have this protection and therefore received no justice in her loss of life, no accountability for the pain she endured at the hands of a negligent individual. I've now lived in this unjust grief, having to constantly deal with not being able to see Nayeli grow. I'm now haunted by nightmares and flashbacks, constantly reliving that day. My own screams of pain, the sound of my daughter's breaking bones, and the deafening silence in the absence of Nayeli's first breath are the soundtrack. I urge you not to allow other families to be blindsided, as I and countless others have been. SB 293 has the power to change this, and you have the power to support it. Thank you.
Ashley, thank you for your testimony. Do I have any questions for this witness? Seeing none. Now, I think, is Carrie Craig here? I didn't see Carrie. Carrie, you want to come up? You were part of the panel. If you'll testify, and then we'll have other questions. Thank you.
Thank you. Thank you. Good afternoon, Madam Chair and members of the committee. My name is Carrie Craig. I'm the State Long-Term Care Ombudsman. Thank you for this opportunity to testify. For those of you who don't know about the Ombudsman program, we are a statewide advocacy program. We advocate for the health, safety, welfare, and rights of residents who live in long-term care, which includes nursing homes, assisted livings, and unlicensed assisted livings. We empower residents, we educate staff and the community, we advocate, and we investigate complaints made by residents or on behalf of residents. In Maryland, there are over 54,000 licensed long-term care beds. Our mission is simple but vital: to ensure resident rights, safety, and quality of life. We feel Senate Bill 293 promotes those same values. This legislation ensures that residents and families receive clear notice about a facility's professional liability insurance coverage. That transparency helps residents make informed choices about their care, understand their rights, and protect themselves. There is power in knowledge and in choice. I think we can all agree on that. And as Marylanders, we should all have access to both. Senate Bill 293 advances transparency, accountability, and person-directed care, which are the cornerstones of long-term care. For these reasons, and on behalf of Maryland's long-term care residents, I respectfully urge a favorable report on Senate Bill 293. Thank you.
Thank you. Now, do I have any questions for any of the panel or a virtual witness?
We do have one more witness signed up. I'm sorry to interrupt.
Who do you have?
Nomiki?
Oh, I thought she'd already testified. I'm sorry. Thank you.
That's okay. Thank you, Madam Chair, Vice Chair Hayes, and members of the committee. My name is Nomiki Pestrikos, and I am an attorney at Myers, Robbill, and Rosenbaum, a firm in Prince George's County. And I am a member of the Maryland Association for Justice, and I am in support of Senate Bill 293. I wanted to just briefly share with you all an experience that I had representing a wonderful family with respect to the decedent named Florence Crudup. Florence was an elderly woman who was a patient or a resident at an assisted living facility in Baltimore. And had a bill such as 293 been passed, I personally believe, and the family believes, that Florence would be alive today. Florence was severely neglected and abused and died tragically as a result of the negligence that occurred at this facility. At the time of her death, she was covered in wounds that caused her to develop osteomyelitis, a bone infection, which led to sepsis, and then her death. At the time, during the course of the litigation, we learned that the assisted living facility was not covered by insurance. We then also performed an asset search as we tried to try to figure out whether there were assets, and there were none. The facility had closed. The owner still took part in the lawsuit, and it didn't stop us from seeking justice on behalf of Ms. Crudup and her loved ones. But we did that, and we tried the case, and we received a 7-figure verdict in Baltimore City. And while the family was grateful for this, justice was not served, as the family will never be able to recover from this facility or this owner. And what's important here to understand is that the family was never informed that this facility lacked insurance, and had they been told, they would have never placed Florence in their care. But they were deprived of that choice, and a choice that should have been theirs to make. And they assumed that if something went wrong, they would have been covered, but that was not the case. And perhaps Florence would still be here today if they were told this information. So passing this bill is important to families like my clients and future families who will be pressed to make the decision to place their loved ones in a facility's care. It's not an easy decision to make. And therefore, families have the right to know whether a nursing home or facility carries insurance or not, so that they can make an informed decision regarding the care.
You need to finish your sentence.
Yes, and I urge for a favorable opinion for Bill 293. Thank you.
Thank you very much. All right, so once again, any questions at all for this panel or the virtual witness? So Ashley, I want to thank you for testifying today, and I'm very sorry for your loss. Very sorry that this happened for you and your daughter, but thank you for being with us today to tell your story.
Thank you very much.
That ends the hearing for Senate Bill 293. Thank you very much. And next we have Senator Lamb, Senate Bill 169, Hospitals Emergency Pregnancy-Related Medical Conditions. And I think you're going to bring Lucy Brown and Robin Elliott as your panel.
Correct.
Thank you, Senator.
And while they come up, good afternoon, members of the committee. Apologize, I was over in the House side for our Commission on Public Health briefing. It was a Senate designee, so along with Chair Bagnall. So pleased to be back here. Also had another bill hearing, so I've been bouncing around. So I think we have our folks here. We have Dr. Brown and also Robin Elliott, whom you all know. So good afternoon, Chair Beidel, members of the committee, here to testify in support and introduce SB 169. This is a reintroduction. It should not be too unfamiliar to this committee. This is on hospital emergency pregnancy-related medical conditions. And so for the record, I'm Clarence Lamb, Senator District 12. This bill, as I mentioned, was introduced in the Senate last year, ran out of time in the House. And so, as you recall from prior years, there was a lot of uncertainty around the Biden administration guidance that clarified that the federal law called Emergency Medical Treatment and Active Labor Act, known as EMTALA for short, covered emergency abortion care. The guidance under the Biden administration was pulled back, and although it does not change the meaning of EMTALA, the federal statute, what it does mean is that Maryland patients cannot rely on the federal government protections in place to address potential complaints related to denial of emergency abortion care that is necessary to protect the life or health of a patient. So SB 169 seeks to codify EMTALA, the federal statute's protections for reproductive care here in the state of Maryland in state law. EMTALA has for decades required emergency departments to treat and stabilize emergency medical conditions for anyone that comes through their door. This includes providing pregnancy-related emergency care and potentially life-saving emergency abortions. This bill only covers situations where abortion care is medically necessary to save the patient's life or to prevent serious bodily harm. Again, it's only for situations where abortion care is medically necessary. This law seeks to ensure that Marylanders can continue to enjoy these protections without relying on the federal government to enforce them through the federal statute. While Maryland does not have the same restrictive abortion laws as other states, access to emergency abortion care is not always the same across all of our hospitals here in the state. As I mentioned last year, there were news accounts of at least one patient in a Baltimore-based hospital where that pregnant individual with premature preterm rupture of membranes, a potential life-threatening complication of pregnancy, was denied reproductive care. And that was publicized, I think, in even USA Today. You will hear testimony from Dr. Brown, who's an OBGYN physician practicing in Baltimore, on how these denials or delays in emergency care can have devastating consequences for women's health and also their future childbearing ability. It is important to note that there is nothing in this bill that requires a healthcare provider to provide an abortion against their conscience. We are not changing the current law that protects providers' rights to refuse to provide abortion care. This bill is only codifying long-standing protections to ensure that if a hospital refuses to provide life-saving abortion care, the state health department has the tools that it needs to be able to take action and enforce what was federal statute to continue that protection in place at the state level across all hospitals. You'll also note that the bill folder contains testimony that the Maryland Hospital Association has no objection to this bill. The language was worked out last year with MHA. It is the same language as last year as well, so there are no objections to that. And, you know, the bottom line is the reason this is an issue is that there may be some faith-based institutions that do not that choose not to provide emergency abortion care, particularly since the federal requirements are no longer in place and being upheld. And a woman may end up at a hospital that does not provide emergency abortion care by no choice of their own. If they're having an emergency, a medical emergency, they may be transported by an ambulance to any nearest hospital, and they could end up at a hospital that does not choose to provide emergency abortion care, and that could obviously have life-threatening consequences for that individual. So this bill ensures that long-standing federal protections are continued to be in place for pregnant patients, and when these individuals have an emergency, they certainly cannot pick which hospital they're going to. So this bill ensures that women across the state of Maryland can be guaranteed that they receive life-saving emergency reproductive care here in the state of Maryland, regardless of the institution that they end up with, because of the ambulance choosing to transport them to the nearest facility. So with that, I ask for a favorable report on SB 169. Happy to turn over to other members of the panel and take questions at the end.
Good afternoon. My name is Lucy Brown, and I'm a resident physician in Maryland, and I'm here to speak in support of SB 169. During my time here, I have quickly learned that obstetric emergencies are common, unpredictable, and deadly. At my hospital, we receive transfers from rural hospitals and smaller community hospitals almost every day. Just recently, a patient who I will call Anna presented to her local emergency department with heavy bleeding from a miscarriage. She was uninsured and undocumented, but what mattered in that moment was that she was bleeding and terrified. This smaller hospital did not have the resources to provide life-saving treatment, but they were able to transfuse her 4 units of blood to stabilize her before transferring her to us. At that point, when she got to us, Anna had lost over 2 liters. And fortunately, we were able to quickly move her to the operating room and remove the pregnancy that was killing her. In that moment, it didn't matter if she had insurance or what her immigration status was. It mattered that she was a human being that needed help. Emergency pregnancy complications don't follow a neat timeline. They don't wait for transfer approvals, moral debates, or administrative hesitation. A pregnant patient whose water breaks too early can become septic from infection within days. Miscarriages can turn into massive hemorrhages within minutes. Physicians need the clarity and authority to act, and act quickly, when a patient is dying in front of them. Without protections in this bill, Anna's lack of insurance or undocumented status could have meant delay, transfer while unstable, or refusal of care altogether. In cases of hemorrhage, minutes matter. This bill affirms a simple principle. When someone is dying, we treat them. We do not ask them to prove they deserve it. And that is why I ask for a favorable report for SB 169. Thank you.
Good afternoon, Robin Elliott. I'm here today on behalf of the Women's Law Center of Maryland and the American College of Nurse Midwives. In full support of this bill, we were here last year. And as Senator Lamb explained very well, this bill is simply about giving Maryland the legal tools to intervene and enforce in the unfortunate event that somebody does not get care that they need for an abortion at a hospital. We really hope that hospitals do the right thing. We expect that they do the right thing every day. But there could always be an incident that Maryland needed to address. We don't know if the federal government is going to enforce EMTALA, so this would give Maryland the option. With that, we ask for a favorable report. Thank you.
Are there any questions for this panel? Senator Reedy.
Thank you, Mr. Vice Chair. I have a question about, I have two main questions. One is, there are fines, obviously, from the hospitals. The hospitals would be fined. Where does this fiscal note didn't say, so I was looking, where does the fine go? Where do the fines go, and what are they used for?
I would presume that the fines go back to the general fund, but we can.
It's consistent with where we put all medical type fines? Okay. Mm-hmm. You guys have been referencing EMTALA, and the guidance there was guidance under President Biden that EMTALA applies to faith-based hospitals. That's now been rescinded. So I feel like the discussion in the bill and even some of the things in the fiscal note were like acting like it's sort of ambiguous. I mean, it's been rescinded. So how are we able to force faith-based hospitals to, and look, I think generally this is not going to come up because I'm not aware of faith-based hospitals that wouldn't provide care to someone who's miscarrying. Many religious faiths have a life of the mother type exception to how they operate. I understand there's one type of hospital that may not in the state. So, I mean, if EMTALA has been rescinded, what are we doing? How does this work?
So I can start.
I mean, if enforcement of EMTALA, if EMTALA has been, if that forbidding it to be enforced on faith-based hospitals has been, it's now back to being forbidden. Sorry.
So just to be clear, EMTALA is a federal statute that requires anyone coming through the emergency department to be provided life-stabilizing care. You know, that includes emergency abortion care, and the interpretation under all prior administrations prior to this one was that EMTALA also applies to emergency abortion care, and that's what the Biden administration was enforcing. The interpretation of the current administration is that the current statute, which still stands, does not apply based on their interpretation to emergency abortion care. You know, you would have, and because that's an interpretation, I guess there could be a lawsuit. It could be fought through the courts. Obviously, that doesn't help an individual that's in an emergency department at that moment. And so the intention here is to have a similar statute in place at the state level to be able to address that. Now, you know, we have seen examples here in the state of Maryland where it has been reported even in the press of at least one individual at a faith-based institute who arrived at a faith-based institution here who was not able to get the emergency abortion that they needed, which put in jeopardy the life of that woman. And so that is concerning. These are not theoretical instances that occur. They have occurred. They have occurred in other states as well. And that's why other states are also looking at similar legislation.
In that one case you referenced, was that someone operating because the hospital ordered them to, or that was somebody exercising their own right to not do it, or what were the circumstances? Because it sounds to me like I generally think most of our hospitals, including the ones who have religious objections, do comply with life-saving emergency care for a woman who's presenting in that fashion. So I've heard this before. Last year we talked about there's this one instance that happened. Well, was that found to be something that was a violation of the hospital policy, or like what we're going to change the whole law based on one issue that's happening? I know you're saying it's happening around the country, but what were the circumstances of that one situation?
So I believe that that was not an individual provider's like kind of conscience clause that prevented them from offering that life-saving abortion. That was facility policy. Now, I've heard from other folks who have visited other institutions here in the state who have said that, you know, that they had heard from providers in the emergency department that this is not really an issue because they're able to get to their hospital administrator even in the dead of night to be able to get them to sign off on this procedure for any individual coming through the door. The question, you know, even in that example is why do they need to contact a hospital administrator to get that signed off on? The provider at the bedside, when an individual coming in is bleeding out and they need a life-saving abortion to save that woman's life or the ability for her to be able to have a child in the future, they should be able to make that decision at the bedside with the patient. They should not have to call a hospital administrator. These policies are in place.
Yeah, but you are making a life-ending decision on the other end of that when you're at that stage. But I understand it. Thank you for answering my question, and appreciate it. Thanks.
Cool. Are there any additional questions? Seeing none, thank you all so very much. Now we're going to go to the opposition. To virtual. Unfavorable testimony. Just give us a little bit time for them to log on there. So we should have Laura Bogley as well as Jonathan Alexandra. And I see Jonathan is here.
We can start with Jonathan. Laura's trying to join.
All right, Jonathan, you should go ahead.
Mr. Chair, on behalf of the Maryland Family Institute, my name is Jonathan Alexander. I'm an attorney and legislative counsel, and I submit this testimony to you in strong opposition to 169 because it takes an axe to the root of our healthcare system. It's a cut down to the roots of religious vocation in healthcare as it imposes this flawed ideology, this political ideology that abortion is healthcare. And it does so onto hospitals and providers who hold explicit religious tenets against sterilization and against the intentional termination of life. This language goes further and it eliminates conscience protections for hospitals, for doctors, for nurses who have an objection to performing these procedures. You know, doctors and nurses in our state, especially those of religious faith, have both a scientific and a spiritual compulsion to help those in need and to care for every patient that comes through their doors. And they recognize that in these medically tense, life-threatening pregnancy situations, they recognize that there are two lives, that there are two patients, but that there should still be one ethical framework that should govern care. And that is we should do everything possible to preserve both lives. That's why Maryland, up until now, has embedded protections of conscience in this statute, recognizing that providers must not be forced to choose between their profession and their deepest moral convictions. But 169 mandates a disregard of conscience rights. It dismantles this carefully balanced protections in the code. And for these reasons, we urge an unfavorable report.
Thank you. Next, we will hear from Laura.
Thank you, Madam Chair, Mr. Vice Chair, and members of the committee. I'm Laura Bogley, Executive Director, Maryland Right to Life. We urge your unfavorable report on this bill that is not about emergency pregnancy-related medical conditions, but about emergency abortion-related medical conditions. This bill is an attack on religious freedoms of medical providers guaranteed by the First Amendment and protected under Title VII of the Civil Rights Act of 1964. The bill seeks to codify rescinded HHS guidance that forced hospitals and emergency room physicians in violations of the rights of conscience and Hippocratic oaths to commit and complete induced abortions under the guise of medical emergency. EMTALA never referred to abortion, which is never medically necessary, but only to birth and delivery. And no law in any state prevents medically indicated separations to save the life of the mother. The bill fines hospitals for wide-scale medical crisis for pregnant women created by the negligence of FDA and the state of Maryland itself. Due to the reckless deregulation of abortion drugs, more than 11% of women experience serious medical complications. But the abortion industry callously turns their backs on these injured women, causing hospital emergency admissions to increase by 500% to treat women suffering from failed or incomplete abortions and related life-threatening injuries. But instead of regulating abortion and abortion drugs to prevent this harm, like other forms of healthcare are regulated, this bill would shift the burden to hospitals and medical providers to clean up after the substandard practices of the abortion industry and, in effect, force unwilling providers to become a part of the abortion workforce at taxpayer expense. As a result, many healthcare providers will be forced to leave the state, exacerbating the problem of medical scarcity and depriving women access to quality obstetrical care. This bill stands as a testament to the fact that abortion in Maryland is unsafe for women, and we need clarifying language and medical certainty in our code to distinguish between elective abortions and medically indicated interventions. We urge the state to put patients before abortion politics and issue an unfavorable report. I'm happy to answer questions. Thank you.
Thank you both so very much for your testimony. Are there any questions for this panel? Seeing none, thank you so very much. Tammy, is that it? That's it. All right. That's our final testimony for today. And there's no more business on our desks, so that ends our hearing for today. Thank you all so very much.